from the Center for Precision Medicine and Genomics, talking about genetics with individuals with kidney disease, the basics. Presented by Hila Milo Rasouly, PhD, MSc, GC, Associate Director of Education, Assistant Professor of Medical Sciences.
Good morning, good afternoon, or good evening. Thank you for joining this on-demand video. We are going to discuss today some tips and tricks when evaluating a patient who may have an inherited kidney disease. My name is Hila Milo Rasouly. I'm the Associate Director of the Education in the Center of Precision Medicine and Genomics at Columbia University. I don't have any disclosures that are relevant for this talk. And today I'm going to discuss how to collect a family history and how to draw a pedigree, the inheritance patterns of Mendelian disorders, extra-renal features leading to a diagnosis, how to not miss the clues, what should be discussed before and after genetic testing, and what are the available online resources. Such as just some fundamentals, what would lead you to a suspicion of a genetic disorder? So on one hand, there is the family medical history, and on the other side, the personal medical history. Family medical history, like multiple family members with kidney disease or other associated disorders, or family history of early or sudden death of family members, multi-system involvement in family members, a higher proportion of affected males, consanguinity or geographical or cultural isolation that may lead you to think that even if the parents of your patient are not directly related, they are probably close relatively genetically, or elderly parent. These would be clues on the family medical history side that your patient may have a genetic disorder. On the personal side, multi-organ involvement, so have a syndromic presentation, congenital anomalies, developmental delay, severe presentation or rapid progression relative to age or stage, and the young age of onset of disease. These would be the clue on the personal medical history. So I am not going to discuss with you today how to collect the patient's personal medical history, and instead I'm going to focus on the family medical history. So how do you gather the clues to uncover suspicious family medical history? You're going to become a detective. And as a detective, you need to know which questions to ask that may reveal the clues. Your patients are not trying to hide any information from you, but they don't know what you're looking for. They don't know what responses would be helpful and which ones would not be. And we have all been in the patient seat, feeling suddenly shy, not as talkative as we're usually, not sharing as much information as we were planning to. That's why we're telling our patients to prepare questions and notes ahead of time. So avoid just asking, is everyone well? This would probably lead to, yeah, everybody's good. And that would not be informative. You have to ask very specific questions. It's a time-consuming endeavor. However, it's worth the time investment. And remember, you invest it at the beginning once, and then you are going to just revisit the family history once in a while, but not as in-depth as the first time. You have to be systematic to ask about each person in the family. And I will share in the next slide how drawing a family history can help you be systematic. You need to look at your patient body language. Are they really trying to think about their family members when they're answering a question? Or are they just like answering no, no, no without really paying attention? You may want to explain to your patient why it is important and relevant. Why are you asking about family members? That it's not just by curiosity. It's just you're not just trying to do some small talk. It is really important and clinically relevant. When you're collecting information about family members, be sure to record the age of onset of symptoms. And if it's not known, it's okay. just try to collect that. And collect information on major medical, physical, or mental health problems, on anyone ever needed treatment in the hospital, on any serious illness or operation, and on miscarriages or babies who were stillborn. This can be difficult to ask about, but it is really important when thinking about genetic diseases. Some examples of questions. You want to ask your patient, how many siblings do you have? And you might be surprised, but some patients do not count siblings who passed away. So you want to ask, did you have any siblings who passed away? How old were they when they passed away? Why? How? What happened? And then you want to ask a very specific question. I wrote here a very long question that is not meant to be asked the way it is written right now. The idea is that you have to break this question into small pieces. Does your father have hypertension? Does any of your uncles have liver disease, etc.? The idea here is that you would go over all family members and also all the different disorders that could be relevant. So not just kidney disease and blood in the urine and foamy urine and kidney stones, but also hypertension, diabetes, heart disease, hearing loss, gout. And you may want to also explain and define what gout is. Not everyone knows what gout is. Eye abnormalities. What do you mean by eye abnormalities? Blindness, having glasses, night blindness, psychiatric disorders. Again, you may want to be more specific. Anyone with autism, anyone with schizophrenia, anyone with bipolar disorder. Liver disease, pancreatic disease. Six fingers is one of the signs of some of the ciliopathies. You definitely want to ask about that. Similarly, obesity, even though it is a very common disease, it is important to ask about it, and especially to ask about outliers. Anyone in the family that is especially obese, different from other family members. Now, asking all these questions about all these family members can be very complicated and confusing. And the tool that was developed by geneticists over the years was to draw a pedigree. So for those of you who are not familiar with how a pedigree looks like, these are the standardized nomenclatures. Square is a male, circle is a female. To draw mating, we are drawing a vertical line between the male and the female. For consanguinity, we are drawing a double line. And for siblings, we are drawing a bridge. There are now updated nomenclatures centered on sex and gender inclusivity that you are welcome to go and look in this paper from 2022. I draw here a very simple pedigree and copied it 3 times, just changed who is affected. So the ones who are affected are painted here in black, and the ones that are unaffected are empty circles and squares. The proband, your patient, is marked with an arrow, and in the top pedigree, you can see that your patient is a priori healthy. She's a female and she doesn't have kidney disease. In the top pedigree, she's reporting that her father and her aunt have kidney disease. However, on the same paternal side, she has an additional aunt and an additional uncle who are healthy. All her cousins and siblings are healthy. Her grandparents are healthy. That would be suggestive of an autosomal recessive disease. In the red pedigree, this time her brother is affected and her uncle on her maternal side is affected. She has her mother and 2 aunts on the maternal side who are unaffected, and an additional uncle who is unaffected, and that would be suggestive and not X-linked recessive. On the bottom, You have your patient, her brother is affected, but this time her father is affected as well, ruling out X-linked since the father passed his Y chromosome to his son. On her paternal side, she also has an aunt with the disease and her grandfather with the disease, and that would be suggestive in an autosomal dominant. Knowing about the inheritance can help you provide some kind of a risk to your patient. She is at risk of carrying the variant on the X chromosome if it's X-linked. She's an obligate carrier for the autosomal recessive disease, and she has very low risk of being a carrier for the dominant disease, depending on the penetrance of the disease. So you are drawing here a very comprehensive pedigree, and then you are filling it in with all these extra manifestation questions. So as mentioned earlier, the extrarenal features can lead to a diagnosis, and you really should not miss the clues. Eye abnormalities or blindness are associated with certain diseases, like Bardet-Biedl syndrome or eye anomaly in papillorenal syndrome or in Alport syndrome. Hearing loss, again associated with certain genetic diseases associated with kidney, like Alport syndrome. Heart anomalies or heart diseases, like in the George syndrome. Polydactyly, having an extra sixth finger, is something that usually the sixth finger is removed shortly after birth, and people are not walking around with their sixth finger. So it's something to ask about. Had anyone ever got surgery to remove an extra finger? That could be a clue for a ciliopathy or Bardet-Biedl syndrome, for example. Obesity is associated with, again, Bardet-Biedl and other syndromes. Delayed development, intellectual disabilities, psychiatric disorders. The George syndrome is associated with increased risk for schizophrenia in an older age, and facial dysmorphology. Facial dysmorphology is a very hard thing to identify. We do not expect you nephrologists to become a dysmorphologist. Just as a mention for in the future, we may see that AI and other deep learning machinery will help you with these facial phenotypes. There was a very interesting paper that came out in Nature Genetics in 2019 describing how the pictures of patients could be utilized to identify genetic disorders. So it is possible that in the future we would take pictures of our patients, and that would help us tell us, oh, the distance between the eyes, the distance between our nose and the mouth, or the shape of the ear. These things are pointing to a certain disease. I am going to move on now to what should be discussed before genetic testing. So I would say that the one main point I would like you to take out from today is that the goal of the genetic testing should be discussed with your patient. Why do you want to do this test? This is not a mandatory test. This is different from a regular blood test. Ask, is it just to confirm the diagnosis? Your patient knows that they have Alport. They know that they have ADPKD. Why would they want to do the genetic test? You may want to tell them why you think they should do the genetic test. Maybe it will help you guide management. Maybe it will help you give them a more specific prognosis. Maybe it will help you guide them when they're planning for transplantation. Maybe it will help you avoid unnecessary therapy or access to targeted care or to clinical trials. It can be a discussion between you and the patient. Maybe the patient wants to do the test even though you think that it will not help guide the management. Maybe they just want to end the diagnostic odyssey. They want to know why they have this kidney disease, and they want to utilize all means possible available today in medicine to understand why they developed the disease. Maybe they want to do it for reproductive planning. Maybe they're worried that they will have kids with the same disease. Maybe they're worried that their they will have grandchildren with the same disease, or they will have nephews or nieces or cousins with the same disease. You may want to do that also to help counseling of at-risk family members. So cascade testing is this idea that when you identify one individual with a genetic disease, you can test for this specific genetic variant in all family members who are at risk. First-degree relatives, second-degree relatives, etc. This is a very important reason to do genetic testing. So once you know why you want to do the genetic testing, it can really help you choose the right genetic test. Different tests have different number of genes analyzed. The relevance of the genes analyzed might be different. If you have a patient who just wants to know their diagnosis and they already have a very clear clinical diagnosis, you can probably just test for the genes known to be associated with their clinical diagnosis. GLA for Fabry, the 3 call for 3, 4, and 5 genes for a patient with Alport syndrome, a specific ADPKD panel for a patient with ADPKD, etc. You want to look at which variants are analyzed, and there is another on-demand talk by Del Gaudios that really go through all the different types of variants that can be analyzed. You want to think with your patient about the number of variants of uncertain significance. What would you do with them? What are the expectations about them? So they won't caught your patient off guard and yourself. And whether the test carries the chance, the odds, or the risk, depending on the perspective of the patient and your perspective of secondary finding or incidental finding something that you don't expect ahead of time. You want to have the post-test counseling in mind when choosing this genetic test. If your patient is pregnant and she wants to do the test, how long the test will take and what type of results you may get is extremely important. If your patient has all the time ahead of her and it's actually not really important for her to know fast, but she wants to know everything, then maybe a test that takes longer but is more comprehensive is better for this patient. If the results of these tests are negative, would you recommend a different genetic test? And if yes, then why not begin with this different genetic test? Is it because of cost reasons? Is it because of time? Discuss that with your patient. If variants of uncertain significance are identified, would familial testing be helpful? And if yes, maybe you want to plant this seed in your patient so they can begin preparing themselves and their family members that they might be included in this testing, which is very different from other types of clinical tests. Usually we get tested, but nobody else in the family has to get any test because of that, right? It impacts only the patient. So this is one of the differences between genetic testing and other tests. Okay, so you got the test, you chose it, you sent it, you got it back. What do you do now? So, if the genetic test is positive, which means that we found something, we have a diagnosis. First of all, you should check, does this diagnosis make sense? If the diagnosis makes absolutely no sense, it doesn't match the patient clinical diagnosis, stop, call the lab, triple check. There are errors that are made in genetics also, as was shown in any other molecular or other test, errors can happen. So if the test result doesn't make sense, don't take it as if that's like coming on you and that's the truth no matter what, double check it. So assuming that the genetic result makes sense, the first thing is, does it impact clinical care? So this is a figure from our KDIGO paper, and there are many ways that positive result could impact clinical care. Maybe the condition that was identified is amenable for specific disease-modifying therapies, like Fabry, or primary hypoxaluria, or steroid-resistant nephrotic syndrome caused by COX-10, or cystinosis, etc. Maybe the condition is amenable to non-specific renoprotective strategies like our RAS blockade for Alport syndrome. Or maybe just having this diagnosis would avoid prolonged immunosuppressive therapy, like a genetic diagnosis telling you that the immunosuppression will not impact the disease course. Or maybe you identified a disease that has a high risk for recurrence after kidney transplantation, and that can be a very difficult conversation to have with your patient, but also a very important one. If you identified atypical HUS or primary hyperexoluria or APRT. The condition might be associated with extrarenal manifestations, and that there might be preventive care associated with them. So maybe your patient now is at increased risk for diabetes because of a variant in HNF1 beta, or for intracranial aneurysm because of ADPKD diagnosis. Or you want maybe to send them for screening for renal cell carcinoma because of a pathogenic variant in FLCN. And then I would say that for almost every patient, there is some relevance for reproductive counseling. It might be that it's relevant because your patient has it, but really nobody else is at risk in the family. It's a de novo variant, it happened in them, they don't have children. And that can be very good for other family members to know that they don't have to worry about that. And it might impact your patient themselves for their prenatal or pre-implantation diagnosis. It may impact their nieces, their nephews, their cousins, etc. And Dr. Van Hilde has a talk that is available on demand as well on the impact on reproductive choices. As mentioned earlier, it can impact cascade testing, and it can potentially open the doors for your patient to join specific clinical trials. More often than not, though, the results are not positive, but are uncertain. And you are getting one, two, or many more variants of uncertain significance, or VUS. What should we do? We should not take any clinical decision based on variants of uncertain significance. You have another talk about how variants are classified, so I will not go through that. But definitely, we don't know what they mean, so we should not make any clinical decision based on them. Should we contact the laboratory? Should we order other genetic tests? Should we refer to a genetic study? I'm going now to deep a little bit more into this question of VUSs. So what should we do with variants of uncertain significances of VUS? As I said, no clinical decision should be made based on VUS. You may have read that since one of the major criteria of variant classification is the frequency of the variant in population databases, and population databases are overwhelmingly biased towards European white individuals, non-white individuals have a higher number of VUSs. This is true. This is the case. This should not impact your decision on asking or not asking for VUSs. I think it's just something to have in mind so you'll not be surprised, oh my, how come that this patient has so many VUSs? And this is an important reminder that our knowledge about variants is constantly changing as we are sequencing more individuals, as we are collecting more information, as our knowledge base is growing, our understanding and capacity to classify variant is also changing. Now, if the VUS is associated with a gene that has nothing to do with your patient's clinical presentation, you can probably forget about it. But if a VUS is in a gene that is associated with a disease compatible with the patient's clinical presentation or their family history, so maybe the gene could explain their father or their mother or their aunt, but not them exactly, but kind of, you should contact the laboratory and share this information, because most laboratories do not consider the patient clinical information. So often you do not share it, which you should, but often they don't collect it, so it's complicated. They definitely don't utilize family history when classifying the variants, but this information can impact their classification or at least the recommendation for variant follow-up. So I'm going to go through now all kind of scenarios in which a VUS would be upgraded to a likely pathogenic variant. So first, your patient presentation is highly specific for a monogenic diagnosis. So you have a report of extrarenal features to the genetic laboratory, and that can impact the classification of the variant from VUS to likely pathogenic. This is especially true for if the presentation is pathognomonic, like anterior lenticonus in Alport syndrome, as shown here on the right. But it's also true if there is a combination of symptoms. So your patient has all these things that are associated with Alport, and there is a VUS in COL4A3. Call the lab and ask them, are you sure that we cannot upgrade it? Or is there anything I could do to upgrade it to pathogenic? If the variant is in a gene associated with Bardet-Biedl syndrome, and your patient has all these variants associated with Bardet-Biedl syndrome, if your patient has some ERPIT that would tell you that they may have Bohr syndrome and there is a EYA1 VUS, again, contact the laboratory, and that may lead to a change in the lab classification. If your patient parents are unaffected, showing that the variant is de novo, meaning absent in both parents and happened in your patient, can change the classification. Is actually one of the strongest reasons to change classification. And remember, your adult patients may have parents who are still alive. So it's not restricted to pediatric cases. If we have parents who are alive, we can, and willing to be tested, we can check if a variant is de novo or not. If a variant is de novo, your patient will have absolutely no family history. So having no family history doesn't mean that something is not genetic. For a recessive disorder, if two variants were found and we can show that they are in trans, meaning that they are not on the same allele or the same copy of the gene, that can also lead to a change of their classification. So in the drawing here, the red and yellow are two variants. It is very different if the two variants are coming each from a different parent, are affecting both copies of the gene, or they're both in the same copy. If they're in the same copy, then it's not relevant, it's not diagnostic. Fourth, co-segregation with multiple affected family members. That's usually require many things. Family communication being one, good relationships, being able to actually collect DNA from family members. But if it is available, this can be really impactful. And many laboratories today offer the testing of other affected family members for free to help with the VUS interpretation. So this is also something to remember. And as I said, if you're putting the seed ahead of time, that may help you, because you usually have a certain amount of time for the lab where the lab would do this testing for free. Additional cases with the same variant and the same clinical presentation, if they're identified worldwide, can help. The question is, how would we know? So ClinGen developed this website, Genome Connect, and I would really recommend you to refer your patients to Genome Connect and have them sign up for that. It will allow them to enter their own information, their clinical information, how much information they want, their contact information, and their genetic results, including VUSs. And then they would receive updates through Genome Connect if a VUS was upgraded or downgraded. And as you heard, or you will hear in the other talk, VUSs are often downgraded to likely benign. So that's a great tool that would give the agency to your patients, so then they can take responsibility and being the one who would know if a variant classification changed. Finally, functional studies are one of the things that can impact variant classification. That could be a reason to refer your patient to a research study. It's often done more on the research side, on clinical at this point. However, in the future, with high throughput research developing, it's possible that it will also come to the clinical side. But that's really one of the reasons to refer patients to research. And finally, what do we do if we have negative results? So again, it depends on the goal of the test. And that's why I repeat myself, discuss the goal of the test with your patients ahead of time. Usually results are returned over the phone. It's not a full visit clinic. So really having this groundwork done at the pre-test time is going to really facilitate your discussion. Is the patient extremely disappointed? Would they want other genetic tests to be done? What are the other genetic tests that can be done? If you did a panel, maybe you can do an exome. If you did an exome, maybe you can do a microarray, etc. And then you may want to refer your patient to research studies. Some patients are really interested in participating in research studies, even if they know and understand that it's not going to help them, because it might help their family members in the long term, and it just help society in general. Okay, so I gave you all kind of tricks and tips, and I want to finish with the available online resources. So there are available online resources that are focused on knowledge about genomics, general information, definitions. The NHGRI has a website. The Genetics Home Reference was just migrated to the Medline Plus website, but you can find the same information there. For those of you in the United States, there is a great website organized by the American Board of Genetic Counselors to help you find a genetic counselor and refer. And they even have an option to identify genetic counselors specialized in nephrology. And for those of you in Europe, Orphanet is a fantastic resource to search for expert centers. Again, you do not have to do it all yourself. You can refer your patients. We learned from research that many physicians actually learn best from publications, or at least that they feel that they learn best from publications. We hope that the KDIGO paper is going to be a useful tool for you to go back to and remind yourself. You can print out this table so you can remember what are the potential indications for genetic testing, and you will find the same things that were discussed today. Positive family history is a big thing. Syndromic, multi-system features of extrarenal features are a big reason to refer, and many other topics here in the list. I'm not going to read this out because I'm already over time, but I would also like to point out that for those of you who would like to become an expert in genetics of kidney diseases, there are now fellowships and certificates that are opening, both in the United States and in Europe, that I know about. And I would really encourage you, if you're interested in genetics of kidney diseases, you may want to move your level of knowledge from basic to medium, or maybe to high, and be the people that the others are referring to. So there are many online resources out there that can help you to understand genetic results once you get them. Remember that you may get genetic results even if you didn't order them. Your patient may come to you with genetic results that were ordered by another clinician or by a genetic counselor, and you may need help to interpret them. So you can always call the laboratory that issued the results to ask for help, and many laboratories do have genetic counselors who are there to help physicians. There are also some online tools. So the Guide to Interpreting Genomic Reports Toolkit, I think, is very user-friendly. You have the website Gene Reviews, where you can enter the name of the gene or the name of the disease, and it will provide you the diagnosis, the differential diagnosis, the management recommendations, genetic counseling recommendations for both the patients and their families. And then you have Orphanet that will provide you a shorter description of the disease if you enter the gene name, but it will provide you a directory of expert centers and physicians and ongoing research. It will also provide you links to patients' organizations and inventory of orphan drugs. There are some online resources for variant interpretation. I'm not going to go through all of those. I do not think that all nephrologists needs to enter their patients' genetic results into those and check and verify the lab. This is really the lab responsibility. But if you're curious or you're wondering how come that your patient received two genetic results from two different labs with two different interpretations, that can maybe help you or maybe not. And again, contacting the lab is always a good idea. Additional resources for variant interpretation are gene-based, and they are utilized by laboratory as well. When choosing the lab where you're going to do the test, it's important to make sure that these laboratories are actually experts in the field and utilize all these correct databases. Online resources for patients are important. They can empower your patient, and giving these to your patient can help them navigate the complexity of the internet and the overload of information from the internet. Orphanet, again, is a great resource to find patient organizations across the European Union. In the US, you have the National Kidney Foundation, you have Alport Syndrome Foundation, PKD Foundations, and other. And I would really recommend referring your patients to these. In the US, you also have the National Organization for Rare Disorders, which is a broad umbrella for all rare disorders together.
This talk was brought to you by the Center for Precision Medicine and Genomics.